ياسر.
Bismillah ar-Rahman ar-Rahim. Welcome in this new meeting of Egyptian Society of Nephrology and Transplantation, CME online meetings. Today we are to continue our started series of glomerulonephritis in a clinical pathological case series 4 that we have started since the start of this season. If you remember, we started to address FSGS in two continuous lectures. Then membranous nephropathy was in the third lecture, and this is the fourth lecture, which will be targeting MPGN. As usual, our two great speakers who are concerned mainly with this topic of clinical pathological teaching, Professor Ahmed ELkeraie, Professor of Nephrology and Internal Medicine, Alexandria University, and Professor Wesam Ismail, the Associate Professor of Pathology, Venezuela University, and the Chair of ISN Renal Pathology Group. We are honored to have them today, and we are also honored to have Professor Dawla Bilal, Professor of Nephrology and Internal Medicine, Cairo University, and the past Chair of Qasr Al-Aini Nephrology and Dialysis and Transplantation Center, as our moderator today. May I leave the floor to Professor Dawla to lead this meeting and to listen to our speakers in this surely interesting meeting. Please, Professor Dawla, start.
Thank you very much for the introduction, Yasser. I'm very happy to moderate this this talk with two very distinguished figures. Professor ELkeraie is a very distinguished figure in nephrology and transplantation. And one comment I heard, which is very, very explicit about him from Professor Gamal Saadi, that whenever you want a complicated subject which needs a lot of knowledge, just ask Ahmed ELkeraie to prepare this for you. On the other hand, we have Wesam, who is the reference of nephropathology in Egypt now. I'm sure it's going to be very interesting to have the clinical side and the histopathology side in this topic, which is really interesting, the mesangiocapillary or the membranoproliferative GN, whatever they call it now. And I prefer the mesangiocapillary name. But anyway, please start, Professor Ahmed.
Assalamu alaikum wa rahmatullahi wa barakatuh. I'm very in-depth for the very nice and complimenting introduction, which I really do not deserve from my great professor, Dr. Dawla Bilal. يعني أنا أشرف بأن حضرتك بس تكوني moderator for my humble talk.
You deserve even more, يا أحمد.
بسم الله والحمد لله والصلاة والسلام على رسول الله وأشهد أن لا إله إلا الله. الله يبارك في حضرتك يا فندم. يعني I'm delighted as well to have my dear sister Professor Wesam, which actually I would say I taught a lot from her. I actually relearned the nephropathology again from her, and I assume that I can be her assistant right now. يعني I started to be a little bit of a small pathologist beside her. So I can understand a bit.
with me دلوقتي يا أحمد.
ربنا يخليك يا وسام. And it's nice to be again here in the glomerulonephritis with the initiative of Professor Yasser, جزاه الله خير على كل ما يقدمه للcontinuation after again and again our late Professor Shaisha, which we are each and every time we are here, we remember him and we make dua for him that Allah subhanahu wa ta'ala put this mizan hasanatu bi Allah subhanahu wa ta'ala. So let's go to the work MPGN, or as Professor Dawlat mentioned, mesangiocapillary glomerulonephritis, with the difference between the American and the British nomenclature, is a pathological description. I would start by saying that when you have a patient with glomerulonephritis, first thing to ask is it nephrotic? Is it nephritic? Is it hematuria? Is it chronic progressive kidney disease? Is it RBGN or AKI? These are the different clinical presentation. Then when you go to the nephrotic, you would start to try to say, is it primary, is it secondary, and if it's primary, what type of pathological lesion, and so on and so forth. I would say MPGN is the same. You cannot say MPGN is a diagnosis, neither a clinical nor a pathological diagnosis. When you say MPGN, you have to classify it. And the main issue of today, and this is the, I'm saying this is the take-home message, and let's start with it and end again with it. The take-home message of today is the MPGN has been previously divided or classified or categorized according to light microscopy and maybe EM, and nowadays it is reclassified according to the immunohistochemistry because of the immune microscopy pathology of or pathogenesis of the MPGN. So let's start by having a case and going through the cases to discuss what's going on. This patient is a 47-year-old male. He presented with AKI with a creatinine of 2, previously was normal, a nephrotic range of proteinuria of around 3 grams with no past medical history except for that he was a heavy smoker. And a little bit of anemia. His creatinine was 2.1 and urea 86. And note that his albumin is low, although that proteinuria is 3 grams, but you are justified to say that he is nephrotic, actually because of the edema and of the albumin and the proteinuria, even if it is in 3 grams, not 3.5 grams. But note as well that his urine has an RBCs of 15 to 20 per high power field beside the urinary albumin and an accepted amount of leukocytes. His immune markers was negative, except for that the C3 was a bit on the lower side. And here I would say, please do not forget to do the C3 in front of your preliminary investigation with most of your patients with glomerulonephritis, if not all. The virology was negative and these are slightly elevated and all immune markers are negative. So definitely, and again, with each time we proceed into the clinical pathological correlation, we say biopsy is mandatory. You're not allowed. There are only few exemptions that you wouldn't biopsy a patient with a glomerulonephritis and go directly to treatment without doing the biopsy. In such a case, it's not allowed. You have to biopsy the patient, no role for empirical steroids or immunosuppression. Professor Wesam, what is... Okay, sorry for the technical glitch. So we were just saying that the patient was okay regarding his immune markers and his virology that were negative, except for the C3 that was a bit low. Please do remember that C3 is always in some labs the reference is 80, others are 90, but definitely if you're below 80, it is consumed in the circulation. And then the biopsy was done, and we'll have Professor Wesam to comment.
Okay, this was a good biopsy. Actually, it had around 22 glomeruli, out of which only 5 were globally sclerosed. And as you see, the patent glomeruli, this is a silver stain, and the glomeruli had some what we call exaggerated lobulation. So you can see each lobule as if it's separate from the other one. This is on a low power, but also on this power, you can appreciate that it has some nodular appearance, that there is mesangial a matrix increase. As you can see here, you cannot see really on this power or in this stain whether there is proliferation or not. When we, Ahmed, can we have the next slide? Okay, when we go to a different stain, and this is a PEA stain, now you can see that we do have some mesangial proliferation. We have this nodularity, we have the increased lobulation, and we have glomerular basement membrane thickening with frequent peripheral duplication. Now look here, down there, there is actually apparent duplication in this glomerular basement membrane. Again, here at the periphery, you can see that this basement membrane is duplicated. Here, it's very clear, I think, that we have two capillary basement membranes. You can see the arrow, right? So, and check.
Actually, no.
Seriously?
لا يا وسام. لا هنا.
9
I'll
o'clock.
try to be with you. I'll try
Okay.
to be with you. Would you mean this one? You can mention the
I'm
time.
at around 2 o'clock كده.
2 o'clock, okay.
في 9 o'clock.
Yes, yes. Go down by a bit down. لا جوه.
Okay.
Inner side. This is very difficult.
Okay,
Yes,
okay.
yes,
Here,
you're exactly
here is
here.
duplication.
Yes,
Definite
you see,
duplicated.
yes, you can see the capillary basement membrane duplication clear. And yes, زي ما الدكتورة دولة قالت إن في at the 9 and there is also at 7. It's very clear at 7 o'clock.
Yes.
Again, at the periphery, you can see that there is a significant peripheral duplication. So basically, this biopsy showed a bit slightly enlarged glomeruli. They have a bit of a nodular pattern. They have mesangial proliferation. They have thickened glomerular basement membrane. Can we have the third slide, please? And this basement membrane has significant peripheral duplication. Now, this is a higher power. Maybe you can see the duplication better here. It's in the center of the slide. Yes, where Ahmed showed the pointer. Yes, here you can see also that we have almost two basement membranes, and this is what we call duplication. Next.
Okay, so we had now a description of a pathology that Wesam said that this would be a MPGN, which is a membranoproliferative glomerulonephritis. And Wesam, I would like to have a comment from you. I mean, in some situation with membranous nephropathy, as we mentioned earlier or before, there is some mesangial proliferation. We want to clear this point up that membranoproliferative GN is not simply mesangial proliferation plus membrane thickening. Would you have a comment about this?
Yes.
I mean, in the pathologic, I mean, in the light.
Yes, on the light,
Yes.
even on the light. For an MPGN, you need to see peripheral duplication. To call it an MPGN pattern, as was in your introduction. So in order to say that we have an MPGN pattern, we need to see some at least segmented peripheral duplication. The early cases or within the other differential diagnoses, sometimes the peripheral duplication is not that frequent, but you get instead of it a lot of endocapillary hypercellularity, you get mesangial proliferation, you get inflammatory cells, because MPGN is actually, when it's early, it starts as an active glomerulonephritis. So there is a very big difference, even on the light microscopy, between a membranous with just mesangial proliferation or mesangial matrix increase, as we see in lupus, for example, and MPGN. And also to correct false impressions, whatever amount of mesangium you're going to see in a secondary membranous, it's never going to be like the mesangium you see in an MPGN. So it's not like what we saw in the picture. The mesangial proliferation is usually minimal. And if actually we have a membranous pattern with a lot of mesangium, then this is not membranous. Again, it's not going to be classified as membranous. So don't think that when we say that we have a membranous with a bit of a mesangial proliferation, that you have a lot of mesangia or that it's that obvious or that significant. No, it's not, because you already get these significant mesangial deposits. Even in lupus, when you get significant mesangial deposits with the membranous, then it's a class 2 to 5. It's not only class 5. So this is the point I want to everybody to know, that what we call membranous with the mesangial matrix increase, this is usually, or with proliferation, this is usually a minimal thing which we don't really see a lot. I mean, it's not that obvious. Whenever the mesangium is that obvious and whenever you have proliferation, then something else is going on and you cannot classify it as membranous. So no, on the light microscopy pattern, they are completely different.
Okay, that's excellent. So now we have a patient who presented with a sort of renal impairment with a nephrotic range proteinuria and some hematuria, here biopsy, and the light microscopy. So it's an MPGN. with 5 glomeruli sclerosed out of 22 glomeruli. That's to say the kidney is not so bad. Still, viable glomeruli are more than 75%. So please, again, the message is this is no place for starting immunosuppression. We don't have yet a conclusive pathological diagnosis for the disease. MPGN in light microscopy is not a disease that you would go and treat directly by immunosuppression. Am I correct, Wesam?
Yes, of course. I would have liked first to have a survey of how many of our participants would have just went ahead and were satisfied with such a diagnosis. The message is that this is not a satisfactory diagnosis. This is not a diagnosis. To have on the level of microscopy only something called a membranoproliferative glomerulonephritis, this is not a diagnosis. So this is the first thing. So this patient has to have further workup.
So what's next? Next is you go for immuno, whether immuno is immunohistochemistry or immunofluorescence with preferential levels for different diseases. And Wesam had earlier mentioned that nowadays immunohistochemistry is getting up and up because of the availability of the antibody and the fine techniques that are being used nowadays, giving very good results. So would you have an immunohistochemistry and EM all together because immunohistochemistry alone wouldn't be enough? Or would you start a pulse steroid and maybe immunosuppression immediately? And this was the question that we, I think, answered earlier, but I would leave Wesam to choose between 1 and 2.
Okay, that's a difficult choice. I would have chosen, of course, 2, but to go in an orderly fashion and to follow and to be more practical, we will go for number 1. So we'll go first with immunohistochemistry, and I think next slide I'll explain why we will go first with immunohistochemistry. As Ahmed first mentioned in his introduction, and as you can see, MPGN is just a pattern. And as I explained on the case, this is typically what we call an MPGN pattern. Again, because of the question of the membranous and the mesangial matrix increase, you can see here that we have significant peripheral duplication. You have all of this mesangial proliferation. I'm sorry we don't have a pointer or that you can't really see my arrow, but I think it can be activated from the hosts that you can that I can use the arrow. And so, and as on the diagram, all of these cells, so mainly you have mesangial proliferation here, as you can see on the pointer, and then you get what we call mesangial interposition, and which irritates the glomerular basement membrane, and then you have a new basement membrane formation as a result of this irritation of the glomerular basement membrane. Next. And so MPGN basically by morphology is we can move, Ahmed. You can is mesangial hypercellularity and endocapillary proliferation. Capillary wall remodeling, as I was saying, double contours, and it's duplication. It's not reduplication, because reduplication means we're going to have 4 glomerular basement membranes, because also this is a common mistake. So we have a capillary wall remodeling duplication due to the interposition of the mesangium, and this is what we call at the end a membranoproliferative glomerulonephritis. And a comment on Dr. Dawlat, who prefers mesangiocapillary glomerulonephritis. We can always call it mesangiocapillary glomerulonephritis because you prefer it, Dr. Dawlat. But so for the last years, we have been heading towards unifying of the nomenclature to stop the confusion. Glomerulonephritis is already a very confusing subject. And the nomenclature is very important in order to try to control this confusion. So in a trial to control the confusion and not to confuse what we call mesangiocapillary with mesangioproliferation and so on, there was a choice to stop using the term mesangiocapillary, it's obsolete, and to call it only MPGN or membrane proliferative glomerulonephritis. As I mentioned, the target is that we unify the nomenclature and to make it a more reproducible term and a more understandable term, and to try to limit the confusion regarding the terminology of Okay, so this was one of the major changes we had in our view of how we view the classifications of glomerulonephritis, or how we approach the diagnosis of glomerulonephritis in general. In the past, and this is applicable to a lot of like membranous, for example, as you must have heard from Dr. Ahmed the last session, and again MPGN, and this was the first glomerulonephritis the literature started with, recognizing that this is just a pattern, and that this is a pattern which is very common to a heterogeneous group of diseases. This heterogeneous group of diseases includes a lot of other glomerulonephritis you know of, includes lupus GN, includes IgA nephropathy, includes immunotactoid glomerulonephritis, includes fibrillary, includes monoclonal gammopathies, as we're going to discuss, and so on. However, what we want to call purely a membranoproliferative GN, and not to call it anything else, meaning that a fibrillary GN is a dependent glomerulonephritis, a light chain disease is a dependent type of glomerular disease, and so on. If we just want to call it an MPGN, then our new approach has to be related to the pathophysiology or to the pathogenesis of this glomerulonephritis, not to its morphology. And hence, next, the classification have changed from the old classification, which was basically a morphological classification, which unfortunately some of you still use till now, which is type 1, type 2, and type 3. Now, this old classification have been only based on patterns noted or sites of deposits, to be more clear, sites of deposits by electron microscopy, which doesn't tell us anything. It does not tell us what is the difference. So what is the difference? What's the difference in the clinical presentation, in the prognosis of these patients with type 1 or type 3? It does not give us any clue on how we should approach the management or the guidance, or to guide the therapy of these patients. A pure morphological classification doesn't say anything. So this was the old classification, and this is why the classification was basically obsolete. Next. And we have moved from this classification to a new approach, as I mentioned. And the new approach is, can we have the next slide? That we are going to classify according to immunohistochemistry, according to the immune deposits that we're going to see, because this is what's going to reflect the pathogenesis. And whatever, as you can see in the upper panel, whatever the type that we're going to see in electron microscopy, at the end of the day, as you can see in the last line, in the modern categories, whether we are going to call it an immune complex mediated MPGN or a C3 glomerulopathy will depend on the type of immune complex deposits we're going to see. Usually,
So this is, oh, okay, Sam, I'm just going to overstress what you've said, that it is the division according to immunoglobulin, complement, or both together, and this would recollect the previously known type 1, type 2, type 3, but in a more specific way.
exactly.
That is related to the pathophysiology, and hence to the cause management, as you will see later, is directly directed to the pathophysiological mechanisms of the occurrence. And please memorize this last part of the slides, because whatever is coming later is dependent on this part. And is it the immunofluorescence or immunohistochemistry, whether it is a complement, it is an immunoglobulin, or it's both immunoglobulin and complement, and it will culminate into the previously known type 1 or type 3 or the C3 glomerulopathy with the subdivisions. Please go on, Wesam, again.
Exactly. The only thing is that within the old classification, a type 2, and it had always been actually, we had always called it dense deposit disease, and we've always known that patients with dense deposit disease have only C3 deposits, and we've always known that these patients have the C3 nephrotic factor and that they have low C3. So this was not a new finding. This was just refocusing or reorganizing our scientific knowledge into a more a practical approach to manage our patients. So whether MPGN type 1 or type 3, they can be both classified into immune complex mediated or C3GN. However, type 2 is mainly limited. Also, whenever we have an MPGN type 2 on EM, then this is definitely a C3 glomerulopathy. Okay, next.
So the new thing is that C3 consumption with an MPGN pattern is not equal to type 2 MPGN, which is dense deposit disease. It can be even type 1 or type 2 or type 3.
And it can be immune complex mediated. Remember that
definitely, if you have an
the first name for an MPGN was hypocomplementic glomerulonephritis. So basically,
yes, right.
an MPGN pattern is characterized by hypocomplementemia, whether low C3 or low C3 and C4. So this was its original name when it was first ever described. So a low C3 in the serum does not really tell you which type are you dealing with, but it's a very, very useful marker. And I definitely second what you've said, that when we come to consider a GN, please do C3, please do serum C3 and C4 in concordance with the biopsy, because this now, as also you're going to hear later, that the C3 levels is a very good way to monitor the progression of the patient if we're dealing with a C3 glomerulonephritis.
Okay.
Okay, next. So this is again a re-emphasis on the new classification we've mentioned, and that the new classification is basically based on immunofluorescence or immunohistochemistry.
I'll go here and start to mention specific disease entities. Hello, are you following?
Yes, we're following.
Hello.
Say it again,
okay.
yeah, Dr.
Say again.
Okay, I was saying I start mentioning specific disease entities, and then the main message from this part is that an MPGN, which is up here, can end up by more than like 15 types or 20 types of diseases. You can say which one is it. Are you following?
Yes.
Yes, we are with you. Yes.
Okay. So, for example, if you go for the immunofluorescence microscopy and you find immunoglobulin with C3 deposit, both in the capillary and the mesangium, then you would go for immune complex mediated MPGN, and this is the first subtype. Immune complex mediated MPGN, you have to determine the source of this circulating immune complex. It could be a monoclonal gammopathy. It could be autoimmune or rheumatologic disease like lupus, rheumatoid, Sjogren, and others. It could be infection like simply post-infectious GN, or it could be idiopathic, and this is the one that can warrant immunosuppression. So please do remember that 1 out of 4, which is only 1/3 of the whole story, would need immunosuppression. Maybe the others do not. Of course, the autoimmune would need, but would need a specific one, and the monoclonal gammopathy would need something else rather than the classic immunosuppression that we give. So be aware of, it's no way to start after a pathology report of a light microscopy of MPGN by giving pulse steroid or giving the patient immunosuppression, MMF or cyclosporin or whatever, or even azathioprine, just based on this finding. So again, this is the immunoglobulin or immune complex mediated, could be a monoclonal gammopathy, could be autoimmune or rheumatological disorder, could be infection, or could be idiopathy. If you go to the other part, which showed mainly complement fraction, whether C3 or C4. So this is not an immunoglobulin mediated or immune complex mediated. This is a complement mediated MPGN. And for the complement mediated MPGN, you have to look whether it's C3 or C4 dominant type in the biopsy by staining. If it is C3, which I think Wesam would tell us that it might be more common than the C4, you would go for the electron microscopy. And that's why the choice was number 2, that you would have an immunohistochemistry and EM all together, but definitely the immunohistochemistry up front after the light before the EM. Then you have a C3 glomerulopathy, you would go for electron microscopy. And based on the electron microscopy, you would say, is it a C3GN or a C3 dense deposit disease, based on, as Wesam mentioned earlier, whether the deposits are intramembranous, sausage-like in dense deposit disease, previously known as type 2, or it is subendothelial only, like in C3GN. The same is for the C4. It can be C4-DDD or C4-GN. And when you have this is not the end of the story. You would go back to the lab, not the pathology, but the lab. And you would look for the dysregulation of the alternative pathway of complement. And this is a very important issue that we are going to overstress in the next few slides. Going back to the lab, both genetic lab and the lab for autoimmunity, or I mean for autoantibodies and for the complement factors, all of them. You have to look for mutations or antibodies to complement factors or complement regulating protein, and we'll come back to this later. Going to the third part of the story, if the immunofluorescence shows no staining for IgG or for immunoglobulin, nor for C3 or C4, then you're going to diagnose the non-immune type of MPGN, which is actually another total story that we will not even be able to cover during this session, but it is a confusing type of disorders that gives the picture of MPGN on a light microscopy, but by the immunofluorescence, you would find there is no deposit, no complement factor, and no immunoglobulin. It can occur in TMA, in APL, in nephropathy of PMT, and in even chronic allographic nephropathy, which the very famous term of transplant glomerulopathy, which is duplication, and even with radiation nephritis and the malignant hypertension causing some sort of chronic TMA. Wesam, would you like to show some pictures here?
Oh, yes. So yeah, confirming what we've been saying. So this is how we look at an MPGN, that it's either, as you see on the upper panel, a C3 glomerulopathy, what we call dense deposit disease, or C3 glomerulonephritis, and then immune complex mediated MPGN, or infection-related GN, which is now tightly also related to C3 glomerulonephritis, as we're also going to discuss. Just a comment on the C4,
yeah,
as you've asked.
Yeah.
Well,
Yeah.
I'm not sure that we do have this entity definite, because it was only 2 cases which were described in the literature. There was no follow-up.
Okay.
And I don't want to complicate things or to confuse everybody, but I want to tell you that it's not uncommon. It's not common, but it's not uncommon to find within C3 GN also a strong C4D staining. So they are dominant. And it seems that some patients, their problem with the alternative pathway also activates somehow the classic pathway, or activates also C4 deposits. So we still don't know what's behind this, on whether these patients with both deposits are different from the patients with only isolated C3. We don't have any further cases or any reports about a pure C4 glomerulopathy. I remember that I once had a case and I just doubted the staining, but for now, there are very, very few cases. I think I'm not with the author where you got the classification from, that we are able really to define a new disease, or to say that we have patients with only a C4 deposits yet.
Okay, that's a good point. So it's debatable on the pathological side. I would like to comment. I'll take your hat, Wesam, and say, look here for the intramembranous deposit, which is a sausage shape or lipin-like, as we previously mentioned, used to say for the students. This is dense deposit disease. Look here for the subendothelial deposits in the GPM, and here Would you say this is a hump, Wesam, subepithelial hump, these particular parts?
Yes, they are.
Okay, and these,
but also you can get subepithelial humps with C3 glomerulopathy.
yes, okay. So this goes for the infection related. So it's now all about the pathological and the clinical diagnosis, and the very nice picture of mesangium that is everywhere, lobulation اللي احنا بنقول عليها بالعربي فصوص البرتقال, as you can mention it, you can see it, just to simplify things. And very crowded glomerulus with very narrowed capillary lumina from the proliferation, and the clinical presentation can be anything. Mostly it is a nephrotic syndrome. Sometimes it is nephrotic or nephrotic, which is the commonest presentation in this type of patient. Definitely it can be an RBGN. A chronic GN, as we just mentioned with Wesam previously, is not a pathological terminology. It's rather a terminology of the fate of a patient who passed unnoticed or an indolent GN, which occurs mostly in cases of FSGS that may be secondary with not a very obvious presentation, and proceeding till having a patient with a scarred kidney. Asymptomatic, I wouldn't say it's common in clinical presentation of MPGN, because usually even with a hematuria, you would have some hypertension, but isolated hematuria or isolated proteinuria in a low range proteinuria would be astonishing to have it to have the result as an MPGN. And this is all about the pathogenesis of MPGN, which is the complement pathway. And as you all know, the complement pathway here, classical pathway, starts by a pathogen that goes through the C1q, and the key factor here is C4. Lectin pathway, which was recognized in the previous time, which goes through the mannose residues, and again goes to the C4 pathway, or the alternative pathway, which is secret behind our MPGN or C3 or complement mediated glomerulopathies with different type. And the alternative pathway, as you can see, can occur from a bacterial toxin, a lipopolysaccharide, or whatever. And it's all about C3 and T3 activation. And look for all these types of proteins and complement factors, both stimulating and inhibitors. All these are to be tested for when you are sure that this is a C3 glomerulopathy or glomerulonephritis. So it goes here from the C3. You can have complement factor H, complement factor I, the MCP, or you can have the properdine, you can have the BB or the C3 convertase. Even all these factors can have implication in the final testing for the final diagnosis of the patient, again and again, for the planning of the treatment and for the transplantation later on. In all the way, it's the C5 that goes into the C5b9, which is the membrane attack complex. That is the end result of the activation of the complement components. Please to remember again that C3a and C5a are called anaphylatoxins, and these by themselves can cause inflammatory reaction. And going to the pathogenesis and the study that showed these clusters of patients, whether in the fluid phase complement activation or in the solid phase complement activation, measuring different type of different proteins that are related to the complement, whether it is mutation in the genetic codon or C3 or C5 nephrotic factors, and definitely measuring the serum C3, the plasma membrane attack complex, glomerular IgG or glomerular C1q, or even the electron dense deposit, you can see that there is different levels in different situation and different scores in the immune microscopy. And this complicates things more. You cannot anticipate simply by adding, and this is the difficulty in detecting the issue behind. It's a heterogeneous group. Even with the C3 glomerulopathy or C3 glomerulonephritis, it is a heterogeneous group, yet all related to the alternative pathway, but it can be any of 5, 6, or 7, or maybe even 10 abnormalities. And you have to look it for, it's difficult to find out the specific etiology. So let's go back to case 1. What happened? Immunohistochemistry revealed IgA negative, IgG diffuse GPM deposit, and C3 deposits along the glomerular basement membrane. Wesam, would you comment on that?
Well, you can comment as well, Ahmed. As you can see, this is the IgG immunoperoxidase, and the positive is the brown staining. So you can see that the basement membranes are all outlined or almost marsumin. You can see them drawn all by this brown staining. This was for the IgG on the left, and on the right, the C3, which tends to give you a more of a granular pattern. Here, they were more or less with the same intensity. Maybe the IgG a bit weaker, which is again common in MPGN. And so this case would be classified as an immune complex mediated MPGN because we had both. Yes, so we have both. We have immunoglobulins and we have C3. And so it goes back to Ahmed to decide which one of these is it.
Excuse me, Wesam, before going back to Ahmed, and excuse me, Professor Dawlat, you said in the previous picture that one is for IgG and other for C3, but I can see that both are the same. Can you explain the difference, please?
Oh, you mean the difference in the picture? No, there is no difference. If we labeled the slides wrong, then we are going to get it mixed up. We label from the beginning. The same is for immunofluorescence. With immunostudies, labeling is the most important thing. If we did not label properly, then we have them all wrong.
Okay, this is a very important teaching point from Professor Yasser to the floor. You should know that you can never identify the antibody that is being stained by immunofluorescence or immunohistochemistry unless you have been told by the pathologist what is this. You can tell where is the pattern. Is it mesangial? Is it membranous? And you can tell whether it is granular, fine granular, or coarse granular, or uniform. But you can never tell is it IgA, IgG, C3, or antiplar, or DNA GP9, or C4D, or whatever, unless you have been told. Maybe this is for Wesam, she can tell some of these out of the pattern because she's very Aruba, but we cannot do that.
I remember when I was doing my MD.
Can I have a question for Dr. Aruba? If it's an immune-mediated type, you can differentiate between the different types of the immunoglobulins or not? As a pathologist.
Yes, of course, because we stain for all. We stain. It's again by labeling or staining. I was saying that when I was preparing my MD thesis, I used to stain the immunohistochemistry myself, not the technician.
All right.
So I stained 60 slides for 5 antibodies, and I forgot to label them. And after spending a whole night awake waiting for the results, I had to throw them all. اضطريت ارميهم كلهم في الزباله وابتدي من اول وجديد. Seriously, because I didn't label them, so I had no clue what was what. By experience, of course, I have to also to mention a very important point. This is a very important point عشان المراجعه والconsultation cases. Immunofluorescence is a technique, and any technique بيبقى lab dependent. In general, pathologists get experienced with their own stains and with their own techniques. So I can interpret my stains, Yeah, although yes, of course, if they are unlabeled, it's going to be a problem. But by time and by experience, I get to know, I can differentiate where the problem is or if something is mixed up. فده ما بيبقاش لما باجي اتشيك or when we look at slides جايه من بره او immunohistochemistry جاي من another lab. It's not always that easy to judge على الimmuno slides in specific. Then, as I said, every pathologist should be more familiar with their own techniques بالfallacies بتاعتها.
But at the end of the day, you will give me a result. That's right?
Yes,
regardless of the technique. What
yes.
I mean is, to simplify matters, if I have a pattern for infection, it is polyclonal, right? If I have a monoclonal pattern, it's for dysproteinemias and gammopathies.
Yes.
Or if I have a full house, it's an autoimmune. You can give me this result?
هو احنا I can give you هو دكتورة دولت what we do is that we stain routinely. يعني this case زي ما أحمد ورى الريزلت بتاعت الإميونو كانت IgE negative. And I stopped using IgM لأنه بيدي non-specific deposits, but we have IgM as well. Let's say it's IgE negative. ال IgM ممكن يدي positivity في ال MPGN على فكرة, especially لو HCV. وبيطلع يعني we look at all of them وبنشوف what is positive and according to the positivity بنركبها على light microscopy picture and then you come up with the diagnosis.
Okay.
Yeah. Meaning
and I see in this result
a full house pattern, you can have a full house pattern in infections by the way.
Yes.
هي لازم تركب على اللايت microscopy, but yes of course we stain the whole battery وبعد كده بنشوف what is positive. So I tell you that this is IgG positive, this is IgE positive, and this is how we diagnose.
Right. And I see in the report here in the C3 is +3 or IgG is +2. So this is a predominant C3?
No.
يعني C3 هنا أعلى من من ال other
immunoglobulin. C3 no. A predominant C3 by definition, or what we call C3 dominant glomenephritis, has to be 2 grades higher in intensity. يعني هنحتاج IgG يبقى +1. Than the rest of them.
Okay.
Okay.
So this is not a pure C3. This is
no. You can see
globulin plus C3.
The IgG is very strong. So
okay.
يعني ال 2 plus دي is intensity وممكن تفرق في يعني وقت ال evaluation يعني. هو in general C3 دايما بياخد 3. يعني C3 دايما بيطلع strong في الحاجات الهايبوكومبلمنتك. في ال MPGN في اللوبس دايما ال C3 بيبقى عالي عن مثلا IgA-nephropathy أو حاجة كده.
اوكي. لكن في ال C3GN ما فيهاش خالص immunoglobulins؟ ده اللي انا عايز اساله.
لا ممكن يبقى فيها immunoglobulins بس بتبقى اقل كتير, اضعف كتير من C3. وبرضه بيعتمد الدنس ديبوزيت ديزيز ما فيهوش خالص C3 بس.
اوكي.
You don't get any trace of immunoglobulins. لكن ال C3GN ممكن تلاقي trace, ممكن تبقى +1, ممكن تبقى +2 يبقى C3 +4.
بس it's the ratio between them هو ده اللي بيفرق, right?
Exactly. You have to have a very dominant C3 staining.
Okay. والفرق بين C3 وال dense deposit is a distribution of the deposit.
We will show you. We're going to get to it, and I have pictures which is going to demonstrate. Okay.
Wesam, I would go for a technical point I have to mention actually. A lot of cases from some pathologists or some maybe labs that is not processing enough the tissue or staining enough in a very nice way, especially for the immunohistochemistry, would give you a false positive result. And this especially occurs with the edges of the slides and occurs with the imbibing of the big molecules like the IgM, as you mentioned earlier. So we have to be again cautious in interpretation of the results. I mean, don't take everything. And as you know, يعني with all due respect طبعا دكتورة أروبا وسام, but you know the clinician should be the filtering pathway for every lab result that he gets. Because after all, you are the one who is facing the patient. So sometimes we have a false positive results in immunohistochemistry, usually because of a poor technique of staining. Would you agree with that, Wesam?
I totally agree with you, Awalan, on the first point that the clinician is filtering. I always get very angry of reports or patients have been treated on reports where the clinicians know that they come from general labs and at least these are not known to interpret renal biopsies. And you should be able to properly evaluate the pathology report, to properly evaluate whether this report matches the clinical presentation of your patient or not, where you should be able when to know that you need a second opinion, you need to consult, or you need to call up your pathologist and say that I'm not convinced, it doesn't go with the patient, could this be possible? فبالعكس, this is not disrespectful to the pathologist. This is very important for, as you said, filtering and to give your patient the best chance and the best management you can give him. It's your responsibility. So part of the responsibility of the nephrologist to know when you have a proper renal pathology report, to read the pathology well, to evaluate whether the pathologist has experience in renal pathology or not. So is he qualified to فعلا interpret this biopsy or not? And to ask, it's your responsibility to make sure of your diagnosis if the diagnosis doesn't fit with the clinical picture of the patient. So this is number one. Number two, yes, let me just say, to be very fair, immunohistochemistry on renal biopsies is really difficult. It's a very difficult technique to interpret, for the interpretation. It needs very good experience, محتاج very good quality control, محتاج controls. هو مقرف في الحقيقة. yes, unfortunately, مش كل الباثولوجيست عندهم very good experience with immuno, so they can fall for the trick of false positivity. ودي مشكلة الimmunohistochemistry. وأنا مثلا I always recommend for any startup labs or any startup renal pathologists or labs with they don't have a great experience that they use immunofluorescence because it's much easier in interpretation عن immunohistochemistry والfallacies فيه أقل كتير. بس طبعا ده مش دايما بيبقى available. But what you said is very true. مش بنخبط في حد بس again the immuno results has to match with the clinical presentation of the patient and with the light microscopy. زي ما دكتورة دولت سألتني يعني انت تقولي لي ده فول هاوس، تقولي لي كده وانا كده اعرف ان هو لوبس. لا هي مش كده. هو ان انا لو هو انا عندي full house pattern فعلا then this has to match with what I have on the light microscopy and with the clinical and serological data with the
clinical picture يعني.
Yes,
يعني
this
لو
is how
واحد هيباتيتس هيباتيتس سي وعنده الفول هاوس مش هقول عليه لوبس يعني.
Exactly. Thank you very much. ساعتها ممكن يبقى جزء من الفول هاوس ده زي ما as I mentioned ان ال MPGN اساسا ممكن يبقى فيها IgM عادي IgG or IgM ده عادي، ان ممكن يبقى فيه non specific trapping، ممكن يكون فيه false positivity، ممكن تبقى ال IgA overscored او اتقرت غلط وهكذا. هو this is exactly thank you very much. فمش معقول ان انا يكون عندي عيان HCV positive والعيان ماشي كله HCV positive and I have an MPGN pattern flight microscopy وبعدين يطلع لي diagnosis of lupus علشان الاميونو طلع full house وبعدين as a nephrologist I should accept this. I have to make sure فعلا ان مش هقول لا خلاص ده ما هو الباثولوجي قال ان هو full house ما هو يبقى lupus، مفيش حاجه اسمها كده.
لا ما ينفعش. الكلينيكال بيكتشر زي ما الدكتور احمد قال.
Good evening.
The consortium.
Good evening, professors.
Let me go and leave. Hello, Dr. Wesam. Professor Wesam, let me go and leave the discussion.
May I have a question here, please? I really enjoyed the fill up of both Wesam and Ahmed under your guidance and Professor Dr. Dawlat. But considering hepatitis C that highlighted by Professor Dr. Dawlat, how much of cases of cryoglobulinemia affecting patients after successful hepatitis C treatment? So it's sometimes in MPGN we misleading that hepatitis C virus treatment and negative PCR after successful treatment we have to measure as well the cryo even after successful treatment. So do you have a cases to Professor Dr. Wesam of cryoglobulin MPGN after hepatitis C virus treatment?
Yes, I have a lot.
Yes, exactly. I have 2 cases on that MPGN after successful treatment. So I would like to just give a message to the floor that even the patient with positive hepatitis C virus treatment successively and negative PCR, we have to check cryoglobulin and not correlated with the hepatitis C virus viremia state.
Sure, and we'll touch on cryo at the end of this talk. I think we can proceed.
Oh, yes.
I'll touch on cryo and then we can repeat.
Very nice discussion to the end.
Message. Thank you very much, Dr. Hisham.
Thank you.
Okay. Okay. So.
Ahmed, you're muted. If you can hear me, you're muted. You need to unmute yourself.
Yes, probably Yasser muted us all. Okay.
Yes, okay.
Now can you hear me?
Yes, it's clear.
Okay. So the immune complex mediated MPGN, as we said earlier, is a form of MPGN caused by deposition of immune complex. It can be paraproteinemia, autoimmune disease, chronic infection, and the complement is activated through the classical pathway. So that's why you have both immune complex and complement both together. And these are some examples: viral hepatitis C, even after treatment with a mixed cryoglobulinemia, as Professor Hisham was mentioning. And there are a few cases that we have shared with Wesam earlier, and it can present even by crescentic type, bacterial endocarditis, leprosy, shunt nephritis, visceral abscess, even protozoal like schistosoma and mycoplasma, and the immune lupus, Sjogren, rheumatoid arthritis, and mixed connective tissue disease. And the paraproteinemia can be a cause for this type of immune complex mediated MPGN. Fibrillary glomerulonephritis is another one. And lastly, the idiopathic. So it is no role for, after you have a patient with MPGN, you cannot proceed to treatment by immunosuppression. After you have a patient with MPGN and as well immunohistochemistry showing immunoglobulin and complement, predominantly C3, as in our case, you cannot still proceed to immunosuppression except after exclusion of other causes. And this is what you have to do: idiopathic and start immunosuppression, or stain for kappa and lambda, or request EM. And this is the management of our patient. You have to consider it the idiopathic MPGN is a diagnosis of exclusion. You have to exclude all other etiologies, as we mentioned, and then the management would be according to the presentation. That's why, as much as it is heterogeneous in the pathogenesis and in the etiology, it is again heterogeneous in the management. If it is only proteinuria in less than nephrotic range with normal GFR, you would only treat by supportive therapy, RAS inhibition, and nothing more. If it is a nephrotic syndrome with a normal serum creatinine, you would give a limited course of glucocorticoids. That's to say, something like a minimal change. If there is abnormal renal function test, but in the pathology there is no crescents, and that's why again and again in the pathology there are clues for choosing the treatment. If there are no crescents, but there is abnormal renal function test with an active urinary sediment, you have to give immunosuppression added and above of the glucocorticoids and the supportive therapy. Definitely, if it is crescentic, you have, and you again know that crescentic means more than 50% of the glomeruli are affected by crescents. You have to treat by pulse steroid and cyclophosphamide. On the other hand, if the kidney is bad and the fibrosis is extensive and the glomerulosclerosis is extensive, and the eGFR is less than 30 milliliter per minute, there is no value of giving immunosuppression to such a patient who would progress by any means. So you would only go for supportive care alone. So now we've mentioned the MPGN in light, immuno, and EM, and how to classify. And we had a case that was finally diagnosed as idiopathic immune complex mediated GN, presenting by MPGN. We reached this conclusion after exclusion of everything else. The patient had a low C3 along with the complement, with the immune complex in the glomeruli, and the patient actually responded to immunosuppression. His creatinine come down from 2.1 to 1.3, and his proteinuria come down to less than 1 gram, and he was maintained on immunosuppression for almost a year with a good response, and steroids was gradually tapered, and the patient still enjoying a good kidney function till now. So we're moving to another case with another scenario. That is a 29 years old female. She developed hypertension and AKI with a creatinine 1.9, proteinuria 6 grams, 8 months after delivery. So it was not immediate after delivery. It was not a complicated pregnancy. So we could not say that this is related to her pregnancy. Hemoglobin was 10 and the creatinine was 2.8. It was rising from 1.3 to 1.9 to 2.8, and the urea was 148, albumin 2.1, total protein 5, and CRB was 18. Again, there is hematuria, microscopic hematuria, more than 100 per high power field, and albumin was 2+. And again, C3 was consumed, ESR a bit high, every other thing is negative. Definitely biopsy was done, and this was her biopsy.
Okay, again, yes, again, as you see, we have a slightly large glomeruli, and these glomeruli are totally abnormal. And they have some endocapillary hypercellularity. They also have peripheral duplication. Here, the mesangial proliferation is not that prominent. You don't have a lot of mesangial matrix as the previous biopsy. And this is usually what you see with MPGN stages, because MPGN really go through stages. And when you catch it very acute or early, you don't get a lot of mesangium. But by time, as the previous patient and the previous case, you can get more extensive mesangium and you can see the mesangial nodules. So this patient's glomeruli had this peripheral duplication. She had very prominent capillary basement membranes and some leukocytes, some intracapillary leukocytes, what we call endocapillary hypercellularity. Yes. Next.
So this is a duplication of the basement membrane, and these are few busy capillary lumina with cells. Okay.
Yes. This is a trichrome stain, and with the trichrome, you have a bit of a different appearance. You can see that you have the mesangium doesn't look very nice. It looks like it has some nodules in it, very tiny balls. Yeah, here and up there at 11. And you can see, yes, here. So they look green. Again, the basement membrane is very thick. It's duplicated, but you can feel that there is something between these two layers of this capillary basement membrane. But again, this is an MPGN pattern, a full MPGN pattern. Next. This patient had a single crescent, and you can see that this is a cellular crescent, yes, a cellular crescent with inflammatory cells. But again, when you look at the glomerulus itself, you're going to see the same thing. You're going to see a very thick basement membrane with not a lot of duplication and a lot of cells. Now, this is a bit a variability of the classic MPGN pattern. It might look to you the same, but it does look a bit different to us on the level of on light microscopy. But it's an MPGN at the end of the day. The presence of crescents is alerting, and I'll take the chance to tell you that any glomerulonephritis you know of can cause crescents. So, and crescents are just simply an expression of the aggressiveness of the glomerulonephritis. So with membranous, you can see crescents. With MPGN, you can see crescents. With IgA nephropathy, you can see crescents. So you mentioned it. With amyloidosis, you can see crescents. All of these are just an expression that whatever glomerular disease you have is going aggressive. With fibrillary, you can see crescents and so on. So it's not every time that we see crescents that this is vasculitis or that this is lupus or of course it raises the suspicion, and we have to exclude on serological basis, especially if the crescents are a lot. But if you have a single one or two crescents, then you can accept it within the context of this GM. And MPGN in specific, when you see crescents, there are two things you have to think of. Number one is cryoglobulinemia, because we're in Egypt and we have a lot of HCV, and we still do see de novo cases of HCV, not as frequent as before, of course, but it's still there. So when you see a crescent with an MPGN pattern, you should consider cryoglobulinemia. And number two, you should consider a C3GN. So a crescent helps also. It's not common to see crescents with idiopathic MPGN. So when you see a crescent with an MPGN pattern, it should tell you that there is probably something else. It's not just your classic what you call idiopathic MPGN, whether I agree on it or not. Next. Ahmed, can we have the next slide?
Okay. So the immuno?
Yes.
Yeah, I already put it outside immuno.
Yes. And now you can see on the left, this is the IgG, and it's completely negative. There is absolutely nothing in it. And you can see, you can say that you do have some brown staining inside the capillary loops. And this is typically the non-specific positivity. This is just endothelium taking the secondary antibodies. And the tubules is also a non-specific staining. But the glomerulus itself, when you compare it to the C3, or when you compare it to the previous pictures we've shown with the immuno, then you can see that this is completely negative. So this is a negative IgG and a very strong C3. Can be easily graded 3+, 3 to 4+, and the C3 is mainly taking a membranous pattern. So this is a C3 glomerulonephritis or a C3 dominant glomerulonephritis, whatever way you want to call it. Okay. So what do you think the next step should be now?
Okay, so now we have an MPGN pattern in a female who presented by an AKI, progressing renal impairment with proteinuria, hematuria, hypertension, and she's C3 dominant pattern with the MPGN. What's next? What to do? Do EM, do genetic studies, or do both? Again, let's go for the C3 or the mediated MPGN. When the immunofluorescence shows a C3 or C4 staining, and will be a bit conservative with the C4 because of Wesam comment, with the letter or no IG or C1q, do remind the C1q goes with the classical pathway that is activated usually with the immunoglobulin pathway. So that's why a finding of a C1q in the biopsy usually goes more with the immunoglobulin pathway, which is this one. But here, if it's C3 and C4 mainly, so it's a complement-mediated MPGN. If it's mainly would be C3 dominant staining, which is it's a C3 glomerulopathy with the electron microscopy, you can say, and this is C3 glomerulopathy. We have to be very cautious with the terminology. It's again conflicting. The nomenclature in the glomerulonephritis ما فيش أسوأ من كده. This is C3 glomerulopathy and this is T3 glomerulonephritis. So C3 glomerulopathy is a wider term. With the EM, it entails either C3 dense deposit disease. With the EM, you would find the sausage-shaped ribbon-like intramembranous uniform deposit, or the C3GN, you would find the subendothelial deposits mainly. But in both situations, it's a dysregulation of the alternative pathway of the complement as we show earlier, and this is the next step. So after the EM, you have to go for the genetic study to look for the mutation or the antibodies to the complement factor involved in the alternative pathway of the complement. So the EM would help to differentiate whether a dense deposit disease or a C3GN because of the presence of the subendothelial or subepithelial or intramembranous deposits, but not the uniform dense deposit. Wesam, would you comment on these pictures?
Yes. Okay. Back also to our previous discussion, I just want to mention that dense deposit disease can sometimes be diagnosed on the level of light microscopy. As you can see on the picture on the left, really this pattern of the wrinkling of the basement membranes, and we actually do see the dense deposits. Yes, this is very classic of dense deposit. And when you even go a bit to the right, Ahmed, you can see the Bowman's capsule having the same picture. It's fragmented and it's sausage-like, and you feel that you're looking actually at an EM under the light microscopy. You can actually see the deposits, and they usually very nicely demonstrated by trichrome as well as by silver, as I'm going to show you. And you see on the right, again, this is a very nice immunohistochemistry pattern, which is again almost pathognomonic for dense deposit disease. And you can, with the immuno, see, yes, you can see that they are again sausage-like, they are intramembranous, they are very strong, and you have scattered mesangial deposits as well. So although EM is very important, sometimes we're almost 99.9% sure that this is dense deposit just on the level of light microscopy and immunohistochemistry. Next. And this is the silver, and you can see this is a high power, which shows you the silver stain, and all of this pink clumps you see on the basement membrane are actually the dense deposit. Now, this is the black one is the original basement membrane, and when you go with the basement membrane, then you can see that this black line is discontinuous, and it's filled with all of these deposits everywhere. All these pink clumps of deposits. And again, this is dense deposit just on the level of light microscopy by silver and by PES. So we are able to diagnose a dense deposit disease when it gets to this stage only by the level, only by light microscopy. Next, but it's always good, of course, when we have the facility of EM. And this is an EM of the patient, and you can see that this is not this patient, but you can see that this is, again, what Ahmed have been describing, the very dense, the very electron-dense intramembranous sausage-like deposits seen on the left and on the right. And all of these nuclei are mesangial cells. So we have also mesangial proliferation. Again, a very characteristic pattern in EM and is pathognomonic. Next, on the other hand, what we call C3 Glomenephritis, yes, is where you get subendothelial deposits like this one. You can also, yes, here, these are the subendothelial deposits, and you see it also in the capillary loop, but you can also see some scattered subepithelial deposits, and you can also see some scattered intramembranous deposits. It depends which type of MPGN is. So the picture I have here is a type 1 MPGN, which only has pure subendothelial deposits. But if you have type 3, then you can also get subepithelial deposits. And in both, you can also get some scattered mesangial deposits. So the message is that all tests has to be interpreted together, light microscopy, immuno, and EM. The second message is that we don't diagnose by immuno alone, and we don't diagnose by EM alone. We have to have a diagnosis by light microscopy, know what pattern are we talking of, have a differential diagnosis in order to be able to interpret the immuno results and the EM results properly.
Okay.
Also, C3GN, of course, can present with a pure mesangial pattern. It doesn't have to present with, this is just for the sake that we are discussing C3 glomerulonephritis. It can present only with pure mesangial pattern. And these are usually the patients which has a CH5 factor gene. And as you can see here, the immuno is very much highlighting this brown staining in the mesangium, and the basement membranes are clear. So this is also a presentation, a less common presentation of C3 glomerulonephritis, but it is a presentation. So again, maybe I don't know if we're ever going to have a chance to discuss what is called a mesangioproliferative glomerulonephritis, which doesn't exist because there is nothing called mesangioproliferative GN. But again, mesangial proliferation is a pattern, as you can see in this light microscopy, and any mesangial proliferation has to be classified by immuno to know which disease process are we dealing with.
Okay, definitely this is not an MPGN. It's very nice to have this picture to show the normal basement membrane with the patent capillary and just few mesangial deposits here or staining by the C3 positivity. Again, on the left hand, it's a very nice picture of an almost good glomerulus because you know usually ال MPGN بتحس ان النور اتطفى، مفيش capillaries خالص، مفيش lumina within the this is not an MPGN. Wesam mentioned that this is a presentation of C3 glomerulonephritis, which can be MPGN or can be just mesangial, especially with the CH50. So going back to the C3 glomerulopathy and the alternative pathway of complement, and again, it's a C3, and the C3 by the C3 convertase would have C3A, which is the anaphylatoxin, as we mentioned, and then the C3B goes along and causes that complement C5 activation, and then the C5B, the terminal complement complex or the membrane attack complex. And these are the factors that are involved. And unfortunately, these are the factors that you need to test for, both on serum and on genetic level. The C3 nephrotic factor, factor B, D, and properdine, and maybe factor I as well, CH50, and others. And all these just to find out what is the abnormality in the genetic mutation or the antibodies. I have to stress these points. When a patient is diagnosed as a C3 glomerulopathy, this patient either having a genetic mutation that you should test for, and there are different variable motifs of gene mutation that can cause the disease in different factors of the alternative pathway of complement, or on the other hand, and to complicate things more, antibodies to the complement system, and these antibodies can be stimulating or inhibiting antibodies, leading to dysregulation of the complement pathway with the alternative complement pathway. So you need to do the genetic testing, and you need to do the antibodies for some of these factors. And unfortunately, this is a very tedious issue, but it is important. Why it is important? Because of the high risk of disease recurrence in the C3 glomerulopathy, which is the dense deposit disease, and the C3 glomerulonephritis. So you need to exclude before proceeding to transplantation, to try to exclude by all meaning that this is not a recurrent, the rate of recurrence is more than 90% in this situation. And these are some of the known mutation or the antibodies that can cause the autoantibody to C3 convertase, autoantibodies to factor H, autoantibodies to factor B, properdine deficiency, and C3 nephrotic factor, complement factor H mutation by this allele, and this allele, heterozygous mutation for factor I gene, heterozygous mutation for CD46 gene, which is the membrane cofactor MCP, mutation in the gene for complement factor H-related protein 5, as Wesam earlier mentioned, that usually it causes a pattern which is more like mesangial proliferation rather than membranoproliferative pattern. So again and again, you need, when you have a report from Wesam of C3 glomerulopathy, to recheck for this. And it is not totally difficult. It can be done. These are the screening tests that you need to do, whether for the antibodies or for inherited gene mutation. And these are the functional assays that can be done. And I'm here just to tell you that these are doable. So although are a little bit expensive, a little bit rare, not in every lab, but they are there in the reference labs. You can test for most of the complement factors, and you can test for antibodies for most of the complement pathways or complement-related proteins. And these are few studies that showed the different from this factor to the complement gene analysis and the complement antibodies. As you can see, there are different heterogeneity in different studies from different countries and from different clinical presentation and survival of the kidney, as evidenced by the serum creatinine. Back to our patient, we had a Wes analysis, which is available in Cairo actually, which is a whole exome sequencing. You send a good pathological report with a good clinical report about the patient scenario, and they choose the panel of genes that are to be tested. In this instance, they test for the panel of glomerulonephritis genes that are involved up till now in the known literature. And fortunately, there was no pathogenic or likely pathogenic variant detected in the patient phenotype that account for the patient phenotype. And this is the report. Of course, it's a big report, and it gives you the mutations and if any, and the gene that have been tested. It's like a 10-page report. And if you have a positive report, it is not the end of the story. If you have a positive report, you have to do a further step, which is called a Sanger analysis, which with this Sanger analysis can tell you whether you really have this mutation in this specific gene or not. So our patient did not have a genetic variant of C3 glomerulopathy, and we are awaiting for the result of the autoantibodies for some of the specific complement-related protein to find out what causes her C3 glomerulopathy. And this is a differential diagnosis of a C3 deposit. Emphasize the point that a C3 deposit is an important finding in the pathology report. You have, whenever you have dominant can 12 weeks. If you still have low C3 in the serum after 12 weeks, and if you have a repeat biopsy and there is still a positive C3 in the biopsy after 12 weeks from a presumed post-infectious GN, so you are moving from post-infectious GN to a C3 glomerulopathy. And this is a very important point. A dense deposit disease is 1/3 of the C3 glomerulopathy, whereas A C3GN is a third of C3 glomerulopathy, and we've mentioned the difference between both, mainly in the electron microscopic finding with the sausage shape or the subendothelial and or subepithelial findings. A paraprotein associated glomerulonephritis can give you a C3 deposits in the glomerulus, because complement dysregulation can be caused by the paraprotein, whether heavy or light chain, mainly on factor H autoantibody or nephrotic factor, and it can even give you a targeted therapy, which definitely would change the prognosis of a C3 glomerulopathy. On the other hand, the immune complex idiopathic glomerulonephritis can be associated with dysregulation, and the transition from C3 glomerulopathy and vice versa can occur. And the biopsy confirmed C3 glomerulopathy might be classified as immune complex mediated GN by pronase unmasking these immunohistochemistry. You can use a pronase over the slide that can unreveal a masked antigen in the slide. I'm sorry لان انا بعك في السبيشاليتي بتاعتك يا وسام.
Go ahead.
Okay. Okay, so this is a post-infectious GN. For the sake of time, you have just to differentiate between post-infectious and C3GN. The most important point is the persistence of the low level and the complement deposits in the glomerulus after 12 weeks. If you go later to the paraproteinemia, I wouldn't stay here. We should have a full session for the paraproteinemia and the classification. You would have here the immune globulin derived amyloidosis with the AL subtype, the fibrillary and the monoclonal immune deposits, the proliferative glomerulonephritis with monoimmune glomerular deposit, the POIM and the C3 glomerulopathy, cryoglobulinemia and the cryocrystallobulinemia. And then according to the pattern of deposition, whether organized or non-organized, you have to go through all these. And here, when you don't have an immunoglobulin, but you have a C3, it's either T3 glomerulopathy or TMA. And just have a look, the TMA here is related to the C3 glomerulopathy in one way or another. Even more, you have a miscellaneous etiologies of immunoglobulin deposits. In this part, you would have strikingly enough a membranous pattern, or a primary membranous with a PLAR can go in this part again of the affection. This is the monoclonal gammopathies with the PGN-MID, whether it's IgM, IgG, or IgA. Again, this is out a little bit out of the scope, but it's always glomerular with no tubular interstitial deposits, and it is subepithelial and subendothelial and mesangial as well. And here what you do for the management of a patient with C3 glomerulopathy, you start by having the presentation. This is a revision of maybe what all we mentioned earlier. A patient would present by proteinuria, hematuria, or other marker of glomerulonephritis, including renal insufficiency, hypertension, plus or minus nephrotic syndrome. You would investigate by the basic metabolic level, and C3, C4, ANA, and ANCA, and urea protein, creatinine ratio, hepatitis screen, and biopsy when you have a persistent proteinuria more than 500 milligram, or reduced GFR, or unexplained hypertension with hematuria. The biopsy, if confirmed C3 dominant glomerulonephritis, you have to rule out the secondary forms, which is the classic post-infectious, as we mentioned earlier, and you diagnose C3 glomerulopathy. You assess complement level and activity, and these are the recommended tests. You have to do C3, C3C, properdine, and BB factors, C4 nephrotic factors, and factor H, CH50, and ABH50, and the complete biomarker profile, including the genotyping, as we showed earlier. And then you treat according to disease activity. We've mentioned earlier the treatment according to disease activity. If a normal renal function with the low proteinuria, supportive care, proteinuria up to 2 gram, moderate inflammation on the biopsy, or recent rise in serum creatinine, you give MMF and the prednisolone and deeper the prednisolone. proteinuria more than 2 grams, severe inflammation in the biopsy, and progressive insufficiency on MMF, add pulse methylprednisolone and consider anti-complement therapy, which is unfortunately unaffordable. It is the eculizumab. So this is how you treat it. You give the patient MMF plus a steroid. If it fails, you give eculizumab for the C3 glomerulonephritis. So we come now to the third part, which is the immunofluorescence with no staining for immunoglobulins or C3 nor C4. And these are usually other disease entities rather than an MPGN actually. But it gives you mainly the duplication of the basement membrane. That's why, because as Wesam mentioned earlier, this is the hallmark of the diagnosis of MPGN. I would say the hallmark is the duplication of MPGN of the basement membrane and maybe the lobulation in advanced cases. So it could be a TMA, it could be an ABL, it could be a BMT associated nephropathy, a chronic allograft nephropathy, the transplant glomerulopathy, a radiation nephritis, or a chronic TMA or a malignant hypertension that can present with a duplication as well. So again, just to revise in a nutshell, a pattern of MPGN in the light microscopy would have an immunofluorescence. If it is immune complex IgG with a little of C3, this is an immune complex mediated, and C1q would not be positive here usually because it is positive with the classic pathway more. Determine the source of circulating immunoglobulin, whether it is a monoclonal gammopathy, I'm sorry, C1q would be positive here. Autoimmune or rheumatologic disease, infection, or idiopathic. Again, if it's C3 or C4 with no IgG or C1q because it's alternative pathway, this is the derangement of the complement pathway, the alternative pathway, C3 glomerulopathy, again by the electron microscopy, C3GN, C3 dense deposit, and go through the genetic mutation and the autoantibodies for the complement protein. If there is no complement, no immunoglobulin, go for the alternative diagnosis of a TMA, APL, as we mentioned them earlier. And these can be some biopsies. Wesam, can you give us a clue for the non-immune mediated picture that simulate MPGN?
Yes, but can we go back to the slide of the classification?
Okay.
Thank you. Yes, thank you. So this part, again, emphasizes what we call a pattern of disease. So endothelial, if immunofluorescence shows no staining for immunoglobulins or for complement, so you have an endothelial injury, which is followed by reparative changes, which is basically what we call thrombotic microangiopathy. Again, thrombotic microangiopathy is not a disease, it's a pattern. It's a pathological pattern. And so instead of the first line with thrombotic microangiopathy, it should be hemolytic uremic syndrome, atypical HUS or TTP. Antiphospholipid antibody syndrome is also going to give you a TMA pattern. Nephropathy associated with bone marrow or graft versus host disease is again a TMA. Transplant glomerulopathy looks like TMA. Radiation nephritis is a TMA. And malignant hypertension is a TMA. So again, this is a very strong emphasis on what we call just a pattern. And thrombotic microangiopathy is the differential diagnosis of an MPGN pattern. And again, it's just a pattern. All of these are diseases which are going to give the same picture under light microscopy. So can we go to the pictures? Yes, thank you. So on the left, we have, again, a classic MPGN pattern. And please tell me if you can differentiate it from the previous pictures, because it looks exactly the same. You have peripheral capillary basement membrane duplication, you have endocapillary hypercellularity, you have minimal mesangial proliferation. So you have the whole enchilada of what we call an MPGN. And I remember years back, more than 10 years, I had a consultation case for a young girl who was diagnosed on the base of light microscopy as an MPGN. And the girl took immunosuppression for a few months with absolutely no response. And the girl was a TMA. simply a thrombotic microangiopathy, and she turned to be lupus later on when they followed why she had just this TMA. So it's very, very important to differentiate between both patterns. But as you can see on the level of light microscopy, sometimes it's difficult. So this is by H&E. And on the right, this is a trichrome stain, which again looks identical to the H&E, identical to an MPGN pattern, but this is from a transplant glomerulopathy, which is chronic active antibody-mediated rejection, as I always object on the term can. So this is, again, yes. So this is, and sometimes it's really difficult to say whether this is a full-blown TMA or a transplant glomerulopathy. And it's not important because they are all the continuation of the same process. If you have an endothelial injury, which is going to eventually end on in basement membrane remodeling, in basement membrane duplication, and you are going to get the same picture. So it all follows the same scenario, the same pathogenesis. Next, what clues can tell me in the biopsy that this is a TMA and it's rather not an MPGN? Vessels are very important, especially arterioles. If you have, as you can see with the red arrow, if you have fibrin thrombi, if you can have endothelial swelling in an artery, then this is probably a thrombotic microangiopathy. And you can see on the picture on the right, this is what we call Mccoy degeneration of the blood vessels. Again, this is a finding which is seen with TMA. You can see it in the native, you can see it in the transplant, irrelevant of what is the cause of the TMA. It could be anything. It could be anything of the long list which have just been mentioned. It could be APL, it could be malignant hypertension, it could be a typical HUS, it could be classic HUS, and so on. Next, surprisingly, and I might be shocking to you, and you can object as much as you want, the main differential diagnosis of thrombotic microangiopathy is back to MPGN, and it's cryoglobulinemia. And you will say, how come when you're going to do immuno and cryos is a cryoglobulinemic MPGN and it should be positive for immuno? I don't want to disappoint you, but in reality, cryos are rarely positive in immuno. And a pure active, very active cryoglobulinemia, you're only going to get very weak C3 deposits, plus or minus, as you can see on the lower right picture. And again, you can see that you have, if you don't have this nice pink thrombi within, as in the middle picture, within the intracapillary loops, then you don't know that you are in a cryoglobulin, and it also looks exactly like TMA. On the left picture, on the upper row, you don't have any cryos. You actually have, again, peripheral duplication. You have a lot of cellularity within this glomerulus. As I mentioned earlier, that within an acute, what I call an acute MPGN or a very early MPGN, you don't yet have the basement membrane remodeling, which is more or less a chronic insult. You don't get a lot of duplication. When you get a more florid cellularity, and on the left down picture with the PES, I don't know if it's clear or not, but yes, exactly where you're pointing. These are foamy macrophages or histocytes, and cryoglobulins usually have a lot of histocytes. And this is a very practical way to differentiate if we cannot, on the level of light microscopy, differentiate between thrombotic microangiopathy and cryoglobulinemia. And as you see on the right up there, you also get vascular lesions within cryos, which can easily confuse with TMA. And both of them will give you a negative immuno result. Both of them will give similar EM picture. So I want to stress that these two diagnoses, thrombotic microangiopathy and cryoglobulinemia, are light microscopy diagnosis. Usually EM and immuno is not going to be very helpful if you want to differentiate between cryo or TMA. But if you want to differentiate between a TMA and a classic immune complex mediated, and you don't have immuno, or if you have an inconclusive immuno, of course, within an MPGN, you're going to get the electron dense deposit. Can you move for the EM? The next picture. Yes, thank you. Now on the left, I found this nice EM pictures from one of my patients. Actually, it's the same patient. These two pictures are from the same patient. And this shows you how that you can find different stages of disease within the same biopsy. So on the left, you have a very nice glomerular basement membrane, exactly as Dr. Ahmed is pointing. There is absolutely nothing wrong with this basement membrane. It's not thickened, it's not wrinkled, you have no duplication, you have no dense deposit. And within the capillary lumina, you have all of these inflammatory cells, as you can see them. You have neutrophils, you have eosinophils, and you have some lymphocytes, and you have this flocculent material, what we call a sort of swelling, and this is classically what we call endothelial injury. And you can see the podocytes are all very nicely, only you have only segmental effacement and nothing more is going on. When you go on the right, and this is again from the same patient, but on a different glomerulus, and then you can see where Ahmed is pointing, yes, that you have what we call subendothelial flocculent material, and this widening of the lamina rara interna of the glomerular basement membrane with this what we call flocculent material or foamy material. Again, it's evident in the capillary loops on the right above these ones. Yes, again, this pale color, yes, this pale color subendothelial in the glomerular basement membranes, then you know that you have only an endothelial injury, you have no immune complexes going on, and you have nothing, again, no immune complex mediated injury within this glomeruli. And unfortunately, cryos give the same picture. What's in the textbook, that you have the classic cryo and with the fingerprint and so on, these are very rare to find, especially if you have a chronic cryoglobulinemia. Next. And by time, and this comes from another patient, you're going to get the basement membrane duplication. So this is the first basement membrane, and then you have the second basement membrane inside it. And in between, you have again accumulation of this flocculent material. So this is what you're going to see in EM. You're going only to see basement membrane duplication, no immune complex deposits. You're going to see this in TMA, you're going to see it in cryos, you're going to see it in transplant glomerulopathy. Okay, so finally, I just want to end with some pathology comments to sum up what we've been saying, that the older classification of MPGN, which is based on electron microscopy findings as type 1, 2, and 3, is currently obsolete. So please don't use it, and don't even mention it, and don't ask for it, which type of MPGN this is. It doesn't reflect pathogenesis and cannot guide management to the patients. MPGN diagnosis is based only on immunohistochemistry or immunofluorescence studies to differentiate between immune complex mediated GN, C3 glomerulopathy, or any other entity you want, like monoclonal gammopathy, like fibrillary, like all the long list we have mentioned in differential diagnosis, or in non-immune mediated, or it can turn to be only a thrombotic microangiopathy if it's immunonegative. So the target or the main culprit for diagnosis is actually immunofluorescence. Primary immune complex mediated MPGN is currently a questionable diagnosis, as majority of cases has an underlying disease, mainly infections. I'm not questioning whether you can, if patient responded to immunosuppression, and they can be, of course, there must be a very few patients with primary MPGN, what's called idiopathic. However, the message is that whenever you get an immune complex mediated MPGN, please do an exhaustive workup for infections. And you need to consider a lot of infections, because we're always narrowed in that if it's an MPGN, then we look for HCV and hepatitis B. No, you need to look for schistosoma. You need to look for a whole host of bacterial infections. You can look for other parasitic infections like malaria and whatever it is. So you have to consider all types of possible bacterial, parasitic, and viral infections, which can give you an MPGN pattern before you decide that your patient is an idiopathic MPGN. And if you could not locate an infection, which happens actually in around 40% of patients, and your patient did not respond to immunosuppression, please don't stress, because this means that he's probably not idiopathic, is probably secondary to something that we don't know or we haven't yet diagnosed. I'll end up with this, and thank you very much. We hope that we did not have a very long session for you. It's late at night, I know. And thank you for hosting me as usual, Dr. Yasser and Dr. Dawud. And thank you, Ahmed. Great partner.
Thank you, Sam. Thanks for the audience.
Thank you very much for this very rich and intense session. I'm sure there are lots of questions on the floor, if you can allow them.
Yes, we have some questions on the chat, and Wesam answered them while we were going. But we have a question from Dr. Khaled Abu Zaid about Sjogren syndrome. 50-year-old lady presented with fever, ANA positive, only C4 consumption, C3 normal, renal pathology not yet done. Would you think that the pathology will be C4 GN depending on low C4 level clinically?
I think I already answered that. No.
I would say there's another point in this. Actually, the entity of C4 is not under the autoimmune disorder. Autoimmune disorder should be immune complex mediated, IgG mainly with C3. So the entity of C4, if accepted, it's under the complement mediated with no immune globulin, which would not occur. Usually it's a type of C4 glomerulopathy or dense deposit disease, not Sjogren. I would say for a C4 with the Sjogren, you should go for cryoglobulinemia if you accept Wesam. I think this might be because again cryo is not always only HCV. Being Sjogren, mostly rheumatoid factor is positive, C4 is consumed, test for cryo, and if the patient had a urinary abnormality or abnormal renal function, definitely you would need a biopsy in these patients.
Well, Sjogren usually presents with a tubular interstitial presentation. So this is the common presentation for Sjogren. So if the patient has proteinuria, has low C3, something else is going on. And you should consider that, as Ahmed said, she might have cryoglobuline. She could have also a mixed, an overlap autoimmune disease. So she needs a fractional ENA. She needs very proper, in order to know whether we have something else or not, because this is not a common presentation, or this is not the classic presentation for Sjogren.
Yeah. But I need to stress that if the patient had no urinary abnormality, normal renal function, so a low C4 in this situation does not indicate a need for renal biopsy.
No, it doesn't. It indicates a repeated, a different lab. I would recommend that.
Thank you. Thank you.
Dr. Khaled Abu Zaid wants to add on his question.
عليكم السلام.
دكتور خالد.
دكتور وسام, ازي حضرتك؟ دكتور احمد,
اهلا وسهلا اهلا وسهلا دكتور خالد.
Thank you for this comprehensive presentation for this hard subject. Really, my very simple question. I know well C4 can be related to cryoglobulinemia, but actually this patient have only C4 consumption. My very simple question: is the C4, is this complement consumption, Dr. Wesam, related to the presentation or dominant presentation of the complement in the renal pathology? Very simply, I didn't read any literature concentrating in this issue. If C4 is consumed, did you expect that we will find too much C4 staining in the renal pathology?
No.
That's my question.
No. C4 is consumed in lupus. It could be consumed in MPGN. Some cases of infection, you have C4 consumed. No.
So there is no relation at all in between the consumption in the serum and the dominance of the complement in the renal pathology?
No.
My patient here have only C4 consumption and have fever, persistent fever, have acute kidney injury, and have urinary active segment and Sjogren syndrome, and the ANA is positive.
Well, I would recommend, I would recommend that you do a fractional ENA and that you take a biopsy.
Definitely, she should be biopsied, yes.
Yes, it's going to help a lot. Some patients have C3 glomenephritis, or some patients, they just don't consume the C3. Or sometimes the C3 be correct itself. I don't know, but it's not uncommon and you need not to overinterpret the only low C4. I have seen lupus cases وكان بس ال C4 low وكان ال C3 normal. I have no explanation. Maybe it corrects itself quickly. Maybe what was it represented. بس بيبقى lupus. Again, to answer your question, انت بيجي عيانين اللوبس with very consumed C3 and C4, and you have everything dominant. You have the IgG dominant, you have the C3 dominant, you have the C4 dominant. فالconsumption في السيرم does not reflect what you're going to see in the biopsy.
Okay, thanks so much.
Thank you,
I have a question for Professor Ahmed. C3GN and dense deposit disease are notorious for being recurrent after transplantation. So if you have a lady patient, your patient who's C3, if she goes to end stage, what are the precautions for transplanting this patient?
حضرتك هو ال 2 points. البوينت الأولانية is the genetic testing to find any culprit gene that can be related to the alternative complement pathway. And the second point is the autoantibodies. If the genetic testing is negative and the autoantibodies are negative, I think we can proceed for transplanting the patient. If they are positive, actually, this is a bit out of the scope, but this is another issue because actually the rate of recurrence is different between the different etiologies. Some genetic variants are very highly recurrent. Others do recur, but to a less extent, as well as the autoantibody. If we have to transplant this patient with a known genetic variant or autoantibody, we have to be an oclizumab for life.
Yes, and this brings us to the eculizumab. Eculizumab is an anti-C5, right?
Yes, but
giving it for the C3GN means that the C3GN ends by the
common pathway. Yes,
right?
The common pathway. As you know, Professor Dowlett, there are 3 pathways for the complement activation: the classic, the Mannose, and the alternative pathway. And the 3 pathway ends up at the step of C5b.
Yes,
2,9, which is the membrane attack complex. So we block the common pathway at the end by the oclizumab. But just to tell that Solaris or eculizumab is one among the most expensive drugs in the world.
I understand. Yes. And that's why for countries who give eculizumab, they commission certain criteria to prescribe this drug. One of them is to find C9 in the biopsy. Is this possible, Wesam? Can you find C9 in the biopsy?
C9, we stain for the MAC, we stain for C5 9B. Yes.
C5B9, yes.
Yes, C5B9.
Yes, you can find this in the biopsy?
Oh, yes. We used to stain for it before, because it usually used to give us an idea that you have an active glomerulonephritis, which is consuming complement. بس من ساعة ما ابتدينا differentiate وبقى staining of the complement alone is very important. يعني the role of C5B9 have went back. في some centers لسه بتستعملوا روتين like in Basel مثلا. لكن I don't use it anymore. خلاص we stain for C3, we stain for C4, and we see.
Because one of the factors for commissioning eculizumab in rich countries is to find C9 in the biopsy. Because if you don't find C9 in the biopsy, you cannot give an anti-C5.
That's right. هو ده end result يعني.
But it's easy. If we're going to start using eculizumab, then we can restart staining the biopsy. Commercially available.
I know it is one of the most expensive drugs on earth, يعني.
Yes, exactly. كمان الريزلتس بتاعته يعني among the variants of the C3GN الحقيقه مش promising، يعني مش مشجعه حتى اساسا يعني ان احنا نستناه لما يخلص يعني.
لا هم بيدوه to prevent recurrence in transplanted kidney.
اوكي.
حالات الريكارنس
prevent recurrence in transplanted kidney.
and they have conditions to give it، لان برضه يعني it's extremely expensive، مش هيدوه اي واحد جاله ريكارنس، لازم
صحيح.
يكون عنده C9 في البيوبسي عشان يدرس الايكولزيماب.
والحقيقه الريكارنس ده محتاج يعني قصه لوحدها، لان الريكارنس اوف C3 ده حدوته مختلفه تماما، وهو مش C3 مش بتريكير دايما C3 وكده. لما ان شاء الله لو كان عندنا فرصه مره نتكلم على recurrent GN post transplant.
This is a major one، هو dense deposit disease.
طبعا بس هم they're كمان in a different pattern. They are very interesting diseases الحقيقه.
إن شاء الله will be much more sessions. This tackles an important point that we should order investigations that give us treatment targeted towards a treatment. Must have change a management plan, not only investigations, just for academic reasons. Professor Dalia Roshdi wants to comment.
Yes, thank you, Dr. Yasser, Dr. Ahmed, Dr. Wesam, Dr. Dawlat for this nice meeting. كان عندي بس I have a question to Dr. Wesam. We have a patient with the TMA positive in the renal biopsy light microscope. Would you think that the immunoperoxidase will be positive or negative?
In TMA?
Yeah. يعني كان في patient عندنا كان عنده positive TMA Thrombotic Microangiopathy في الرينال biopsy. What do you think يعني for the immunoperoxidase؟
يعني بتدوري على ايه؟ على C3؟
يعني كل الاميونوجلوبولينز.
لا طبعا بصي whatever the cause of the TMA even in lupus if it's TMA only the TMA is negative. The TMA is an endothelial injury, it's not an immune mediated injury. However في recent article أنا مش عارفة هم حتى نشروه ولا لأ، كان جاي من East Europe، كانوا بيتكلموا على إن sometimes the cases of atypical HUS can give you C3 staining in thrombotic microangiopathy. But this is sometimes and it's a single report ومش validated. بس in general TMA is usually negative وممكن plus or minus C3 ما بنبقاش عارفين قوي how to interpret this C3.
دي المشكلة دكتورة وسام. هو في كان we have a patient 15 years old male كان presenting with rising serum creatinine وبروتونوريا، وعملنا له الكدني بايوبسي. يعني كان في ثرومبوتيك مايكرو انجيوباثي، وكان في ممبرنس في حتت من البايوبسي، وفي فوكال بروليفريتيف. ولما اتعمل له الاميونوبيركسيديز طلع ان في فول هاوس، كان IgG و IgM C3 كان all positive. وكنا actually in a dilemma because he was not a lupus، لأن كل الاميون بروفايل بتاع اللوبس كان نيجاتيف، كان الانتي نيوكليير انتي دبل ستراندد، حتى عملنا له الانتي سميث كان نيجاتيف. فما كناش عارفين
اخباره ايه.
نعم
السي 3 بتاعه اخباره ايه؟
السي 3 كان consumed. السي 3 كان consumed yes. السي 4 كان نورمال والسي 3 كان لو. ودي واحنا ابتدينا نحط differential diagnosis، هل هو يعني atypical HUS، هل هو infective endocarditis، لان هو كان he was young 15 years. هو actually patient ده للاسف he died last week يعني. بس فكانت الدايلما ان التي ام اي كان طالع بوزيتيف في اللايت مايكروسكوب، لكن الاميونو بيركسيديز كان فول هاوس. فكان السجيشن على فكره هو عدى عليكي على فكره في معمل ان يور لاب يعني. كان السجيشن يس عملتيها عملتيها ولد صغير عنده 15 سنه. فكنا يعني كان في اصرار على انه هو سيستميك لوبس، بس اكشولي هو واز نوت ا لوبس، لان يعني عملنا اكزهوشن لكل حاجات اللوبس، هي واز نوت ا لوبس ات اول. كله الانتي نيوكليير الانتي دبل ستراندد، حتى عملنا له الحاجات السوفيستيكيتد الانتي سميث كان نيجاتيف. فكنا مش عارفين بالظبط. قلنا
اوكي.
اتفضل.
هو دلوقتي من الوصف اللي انت بتقوليه the patient has other pathology غير thrombotic microangiopathy في الكدني، مظبوط كده؟ انت قلتي ان كان في حتت فيها membranous deposits وكان في حتت فيها mesangial proliferation انهي حتت؟
فوكال بروليفراتيف، كان في فوكال بروليفراتيف اي ثينك، وكان يعني معلش دي بقى لها اكتر من اسبوعين، بس هو كان في باين thrombotic microangiopathy كان واضح، وكان في fragmented RBCs في السي بي سي، وكان في ان هو كان في فوكال بروليفراتيف، وكان في حتت فيها ثيكنينج في البايوبسي، يعني كان مكتوب كده ان في
كان thrombotic microangiopathy with a full house immunopathy.
يس لما عملنا له الاميونو بيركسيديز انت عملتيها له، فكانت كلها كانت طالعه بوزيتيف، كان في فول هاوس، عشان كده فكرته في لوبس، بس هو ما كانش لوبس. فبس كان السؤال يعني هل الثرومبوتيك مايكرو انجيوباثي عاده بيجي معاه الاميونو بيركسيديز بيبقى او الاميونوفلوريسنس بيبقى بوزيتيف؟ يعني الكلام اللي انا عارفاه ان هو نيجاتيف، المفروض بيكون نيجاتيف الا في حالات اللوبس.
this is what I'm saying. لا حتى لو TMA بس TMA alone بس مش هتبقى positive حتى في اللوبس، لكن العيان ده كان عنده other findings، كان عنده proliferation وكان عنده basement membrane thickening، هو this where the deposits were، وهم دول اللي ادوا الفول هاوس مش TMA. فاهماني؟
الاسوشيشن مع الحاجات الثانيه، يعني قصدك الاذر باثولوجي هو
والديفرنشال
المنظر ده.
Yes, and your differential diagnosis is very valid. ان as we said ممكن جدا طبعا كان يكون infective endocarditis.
بوست انفكشن، هو ده شكله بوست انفكشن كده
بالظبط، لان الانفكشن هو الانفكشن برضه بيديكي فول هاوس باترن.
وقعدنا نفكر بقى ممكن يكون مثلا عنده congenital heart disease وعمل له لان هو كان عنده كمان ابتدى كان جاله sagittal sinus thrombosis في الاخر.
دكتوره داليا السلام عليكم. معلش البيشنت ده البليتلتس بتاعته كانت كام والال دي اتش بتاعه كان كام؟
البليتلتس بتاعته حضرتك بتفكر في تي تي بي صح؟ هو كانت فعلا واطيه، التي تي بي كانت about 70 والال دي اتش يعني هنقول مثلا مش هاي، اتس نوت فيري هاي، يعني حوالي مثلا 300 400 في الرينج ده.
هو يعني طب هو عمل بلازما فارسز ولا ما عملش؟
لا ما هو عمل بلازما فارسز. يس عمل بلازما فارسز 4 to 5 sessions without improvement. ادوا له طبعا الشوتس بتاعت السوليميدرول، اخذ شوتس ستيرويدز وعمل بلازما فارسز، وبعدين البيشنت didn't respond خالص، ما تحسنش، فدخلوا على الريتوكسيماب، ابتدوا يتعاملوا معاه على اساس ان هو ثرومبوتيك مايكرو انجيوباثي، فهندي الريتوكسيماب. خد الريتوكسيماب و2 دوزز بينهم اسبوعين، وهو البيشنت كان ابتدى الكرياتين بتاعه يعلى ودايلايز اكتر من مره، وكان طبعا مركب السنترال لاين فانفكتد، وبعدين يعني didn't respond، يعني هو كان عنده امتحانات بقى وخرج فما عادش في المستشفى. بس فلما جه بعد كده جالنا هو ما جالناش، يعني هو جه دخل الرعايه، كان عنده هيمسفيريك انفاركشن، يعني كان جاله هيمسفيريك انفاركشن في البرين طبعا ودارت. في الوقت ده احنا عملنا له كنا عايزين نكمل، كنا عايزين فكرنا في الاتيبيكال اتش يو اس، وكان المفروض ان هو سكيدجول ان هو يعمل الحاجات دي. اللي قدرنا نعمله له كان الانتي سميث طلع نيجاتيف، الحاجات الثانيه ما عرفناش نعملها له طبعا لان هو ما كانش فيه وقت طبعا. واخر برزنتيشن كان الهيمسفيريك انفاركشن، وكان اتعرض في الروماتولوجي قالوا ان هو احتمال يكون كاتاستروفيك انتي فوسفوليبيد سيندروم.
بالظبط كده بالظبط كده، انا كنت لسه هقول لحضرتك
كاتاستروفيك
هو كان عمل
فوسفوليبيد سيندروم. اتفضل.
هو كان عمل الانتي جلايكوبروتين
يس
وكان ما كانش فيهم حاجه بوزيتيف.
لا كانوا الانتي كارديو، هو كان عنده لوبس انتي كواجلانت، كان الانتي كارديو لايبين كان نيجاتيف، ما كانوش هاي. اللوبس انتي كواجلانت طلع يعني لاستلي ان هو كان مايدلي اليفيتد.
الريشيو كانت ايه بين LA1 و LA2؟
لا انا حقيقه انا ما شفتش يعني انا ده اتقال لي فانا ما شفتش الريزلت قدامي فمش قادره اعرف بالظبط كام الريشيو كانت موجوده.
هو it fits very nicely ان هو يكون فعلا APL ويكون catastrophic APL، وهو ده اللي بيكون فعلا كده اجريسيف بالمنظر ده ويدي TMA يا وسام، مش كده ولا ايه رايك؟
طبعا.
يدي بيكتشر دي
بس مش هيدي
يعني.
الاميونوجلوبولينز الديبوزيشن في
بصي حضرتك
secondary APL مش primary عشان يبقى
نعم؟
عندك
ايوه بالظبط. انا برضو
secondary APL.
I would still say that this is a lupus patient even with negative، واحنا بقى عندنا terminology دلوقتي بنقول عليه البري immunological lupus، يعني ان احنا ممكن يكون العيان، وشفنا حالات كده حضرتك بيطلع فعلا lupus من البيوبسي وبعد فتره يبدا الاوتو انتي بوديز تبان. هو طبعا لغايه دلوقتي الكرايتيريا فور diagnosis 3 كرايتيريا فور diagnosis اوف lupus انه يكون 1 انتي بودي بوزيتيف بلس الباثولوجي الرينو باثولوجي فايندينج. مش لازم يكون في 4 كرايتيريا، الوحيد الاكزامشن هو الكيدني بايوبسي لو suggestive of lupus مع سنجل بوزيتيف انتي بودي بنقول عليها lupus. لو هو فعلا الريشيو بين ال LA1 to LA2 is low ومعاه pathology suggestive of lupus I would diagnose lupus with a complicating TMA من اللوبس. واللوبس انيميل طبعا is very aggressive، وللاسف شفنا كم حاله كتير في الايام اللي فاتوا والبروجنوز بتاعهم is very bad unfortunately يعني.
حضرتك يعني قصدك ايه اللي ممكن يكون مع اللوبس يعني؟
ان هو لو هو
ايه الكرايتيريا؟
لا الكرايتيريا اوف لوبس
لا in this patient قصدي يعني in this patient قصدي
لو هو لوبس انتي كواجولانت بوزيتيف والرينال بايوبسي بتقول ان هو suggestive of lupus، يعني في wire looping مع TMA which can fit into lupus activity او lupus يعني derived TMA، يبقى we are يعني allowed ان احنا نشخص lupus، لانه according to the strict criteria a single positive antibody plus a rhinopathology finding ده الاكسبشن الوحيد انك تشخصي lupus بفايندينج واحد مش 4 زي ما الباقيين لازم يكونوا 4 يعني.
تمام. بس حضرتك الديبيت في البيشنت ده ان هو اكشولي هو ريسيفد اول يعني كل حاجه
انا
ممكن
مع حضرتك
يعني
انا مع حضرتك
يعني هو
ما
ريسيفد يعني الحمد لله هو ريسيفد كل حاجه يعني
ما هو ده اللوبس.
بس هو ده اللي كانت بتقوله وسام دلوقتي ان هو لو ان البيشنت عندنا didn't respond to immune suppression you must revise your diagnosis، لان احنا يعني انا I think ان احنا in Egypt we have a lot of infections not diagnosed، وممكن تكون هي التريجرنج يعني هي التريجرنج بتاع immune process كتيره قوي. فاي ثينك ان البيشنت ده مش عارفه يعني هل هو مش قادره يعني مش حاسه ان هو مش قادره اشوف ان هو لوبس قوي. هو ذا ميل بيشنت هي واز فيري يونج 15 سنه. مش عارفه يعني هو الحاجه اللي بينت في البيوبسي ان هو لوبس، اعتقد ان هو الاميون ديبوزيشن بتاع الاميونو بيروكسيديز ان هو كان فول هاوس، لكن غير كده كان ما فيش اي حاجه تقول ان هو لوبس، يعني ما فيش اي مانيفستيشنز اوف لوبس خالص، حتى العين ما بيشتكيش من جوينت افكشن، ما فيش اي حاجه خالص يعني. مش عارفه، حاسه ان هو ده حاجه لو هو فعلا كان لوبس هتبقى حاجه اكستريملي رير يعني.
انت قلتي ان عنده congenital heart disease يا داليا؟
لا الدكتوره دولت هو انا فكرت ان هو ممكن يكون congenital heart disease. هو كان عمل كذا مره الايكو هارت
سب اكيوت عملته بلاد كلتشر I'm sure you did طبعا يعني.
هو حضرتك عمل ترانس اسوفاجيال ايكو مرتين كان مبين فيه ترايكاسبيد ريجيرج على يعني هو ده اللي كان باين الترانس اسوفاجيال. فانا كنت سجستنج ان احنا نعمل ترانس هو عمل ترانس ثوراسيك، قلت نعمل ترانس اسوفاجيال، فللاسف هو دايت، لكن هو عمل مرتين وكان مبين فيه ترايكاسبيد ريجيرج بس هو ده اللي كان مبينه. ما كانش مبين اي حاجه ثانيه.
برضه حضرتك tricuspid regurgitation in this young male mostly هيكون functional secondary to يعني myocarditis او هيكون اللي احنا بنقول عليه الليبتن ساك اندوكاردايتس، يعني يكون هو ده اللي افكتنج الفالف وعمل كده. فبالتالي this is another point ممكن تكون add on. طب هو الكوز اوف داث بتاعه كان انفكشن ولا كان
لا
يعني
ما هو يا دكتور احمد هو جاله انفكشن في المهوركر بتاعه، وبعدين دخل في سيبتيك شوك، وبعدين دخل الاي سي يو. احنا اكشولي احنا كنا ماشيينه على انتي كواجوليشن، لان كان بياخد ماريفان. وهو لان يعني هو هي واز يونج، وباباه راح موقف له العلاج كله في فتره الامتحانات دي. فدخل بقى بسيبتيسيميك شوك، وجاله هيمسفيريك انفاركشن، يعني جاله
I think يا داليا you should deal with this case من الآخر، إن هو فعلا catastrophic antiphospholipid.
بالظبط.
بالظبط. هو أنا قلت الكلام ده. أنا قلت الكلام ده أساس إن هو لما وقف الأنتي كواجوليشن حصل له كده.
أوكي.
مساء الخير يا داليا، مساء الخير يا جماعه. شكرا دكتوره وسام، شكرا دكتور وسام والدكتور احمد ودكتور دوله. بالنسبه للحاله الساجيتال ساينس ثرومبوزس يا داليا، دي برضو اللي هي كانت في الهيستوري بتاعه، دي مهمه جدا. يعني ممكن يكون العيان فعلا بنشوفها في حالات اللوبس وحالات الانتي فوسفوليبيد. وبعدين زي ما الدكتور احمد اتفضل وقال، الحالات احنا دلوقتي يمكن 3 حالات اتقدموا في الفتره اللي فاتت دي، من كام شهر اللي فاتوا، شكله لوبس بالباثولوجي بكل حاجه. ولما عملنا والانتي نيوكلير نيجاتيف وكل حاجه نيجاتيف، وبعد كده بنعمل الانتي نيوكلير تكنيك بقى اللي بعتناه في المعمل، الانتي
الاي اف
الاي اف
والفراكشنيشن بيطلع بوزيتيف،
وتتر عالي، وتتر عالي، يعني بيطلع واحد على 600، يعني 640 ولا حاجه. ف يعني مع ان نعمل الانفستيجيشنز كلها نيجاتيف، وفي الاخر بتطلع بوزيتيف لو احنا عملنا بالانتي هيبتين. فالساجيتال ساينس ثرومبوزس بتاع الحاله دي مع يعني مع ثرومبوتيك مايكرو انجيوباثي ده، انا اتوقع انها تكون يعني لوبس او انتي فوسفوليبيد اكتر يعني.
mostly yes. لوبس وسكندري انتي فوسفوليبيد والتي ام اي سكندري عليها فعلا. very nice case الله يرحمه يعني. ويعني unfortunately الحالات دي فعلا بتكون very difficult يعني.
يبقى catastrophic فعلا.
وطبعا حكايه الاي ان ار دي it's a good point. معلش يعني مش ريليتد لينا خالص، لكن قصدي للتوبيك بتاعنا، لكن it's a very important clinical message يا جماعه. البيشنت اللي عندهم APL، اولا النيو اورال انتي كواجولانت has no role. they should be warfarinized all the time. واذا كان العيان عنده recurrent venous thrombosis more than 2 attacks of DVT، او عنده single arterial thrombosis، التارجت INR should be more than 3. more than 3. this is very important. مش 2 ولا 2 ونص. وزي ما الدكتوره داليا قالت، الراجل وقف علاج، ابوه وقف له علاج، وربما ده سبحان الله كان سبب في وفاته. ربنا يغفر له ويرحمه يعني.
يا رب. Professor Dawlat, no more comments and no more questions in the chat.
We want to thank very much Professor Wesam and Professor Ahmed Khoureiry for a very rich night الحقيقة. very enriching.
ربنا يخلي حضرتك والله. احنا سعدنا جدا بوجود حضراتكم والله، وفرصة طيبة جدا للقاء الطيب ده. وجزاك الله خير دكتور ياسر ودكتور دولت. تشرفنا والله بان حضرتك يعني تكوني moderating our session يعني. جزاك الله خير يا فندم. الله يفيد. شكرا جزيلا للجميع.
نعم.
شكرا جزيلا.
السلام عليكم ورحمة الله.
شكرا دكتور وسام. Thank you Professor Ahmed. Thank you Professor Wesam for this very rich, very interesting session and glomerulonephritis series, and hope to meet you once again and more sessions. Thank you Professor Dawlat for moderating this session, and thank you for all attendees who enriched this session with the discussions, questions till late night. I think this is the longest session we did since the start of our season.
It was very rich. It was very rich.
Really, we passed more than 2 hours and 15 minutes. Excuse me to close and thank you all again, and announce for the coming one session, which will be next Wednesday. Professor Amr Al-Husseini will speak about hyperparathyroidism, or all the story of parathyroid disease in chronic kidney disease. Thank you very much وشكرا جزيلا، وتصبحوا على خير، والسلام عليكم ورحمة الله وبركاته.
وعليكم السلام ورحمة الله وبركاته.